So we heard such nice talk by Dr. Natarajan sir on the 3D VR surgery, and so I will just be covering the third eye is basically the microscope integrated OCT which I've been using for the past 6 months or so. And this is a case of optic disc pit maculopathy, and I'll just show you the video. So this is the first video which you can see here. Can I have the audio on this? So these are standard steps of ODP maculopathy as stain under air, and then just the juxtapapillary. Can we have the lights down, please? So I do a fovea sparing ILM peeling only in the temporal juxtapapillary area with the main idea, because you saw there was macular thinning there. So I don't want to de-roof the fovea. And then I do an air fluid exchange. So this was a young girl, and almost 18 months, 1.5 years post surgery, you can see that the retinoschisis is almost gone, but there's a pocket of subretinal fluid which is not going away. Vision has improved to 612, 6/9 parts, but not improving any further. And still waited, did some laser on slit lamp in the OPD itself to this temporal juxtapapillary region. You can see some CRA there, light CRA, not dense burns, because you don't want to totally burn out the papillomacular bundle. But you can see that the subretinal fluid has started encroaching the fovea again 2 years after the primary surgery. So I take the patient up for a second surgery, and this time I have MIOCT. So you can see here that I'm just seeing that after staining with BBG, the plug was already there. I confirmed it on MIOCT. I'm moving more ILM onto the pit, making sure that whatever, I don't want to leave anything to chance, and you can see here the nice plug inside the pit on the MIOCT. And then this time I go ahead and peel the fovea, and at the same time confirm on MIOCT that I have not de-roofed the fovea and created a macular hole. So I basically extended the ILM peel to involve the fovea. So initially what was a fovea sparing ILM peel, I've made it more extensive. And I am just confirming on MIOCT, and in fact there is a little bit of flattening, immediate flattening of the subretinal fluid, and I again supplement with little light laser to the temporal juxtapapillary area, and then air fluid exchange with gas. So this patient continues to be on follow-up, but the SRF is regressing and almost gone. This is another case of a diabetic with silicon oil inside, and this is some membranes which have formed, sub-silicon oil. So this is at the time of silicon oil removal. So lot of membranes, but MIOCT, I've realized that I'm using it more intermittently rather than on a continuous mode. Wherever I am in doubt or I am not sure about the planes, I will switch on the MIOCT, and especially if I have a doubt that I have created a break. So a lot of atrophic area with sclerosed vessels, and I'm not sure if I've created a break there. So I just confirm, I take the MIOCT there, like Dr. Natarajan sir and Dr. Tityal sir were telling that we can move the OCT wherever we want inside the fundus, and get a scan of that area instantaneously and take a decision based on that. Patient underwent laser, and this is how the patient looked post-operatively with relatively flat macula there's a small bubble inside. This is a myopic macular hole post RD surgery, and again I'll just show you how I use this MIOCT to my advantage. So at the time of silicon oil removal, I'm doing an ILM peeling for a macular hole which was not there at the time of primary surgery, and just making sure that the peeled ILM is plugging the macula. So just like a flower petal or a cabbage, and then with zero suction I just trim the flaps so that they are not redundant and they don't try to come out of the hole before I do an air fluid exchange. So this is how the patient did with a closed macular hole. So again another case in which there is a diabetic vitreous hemorrhage, and we are not sure, we don't have a view of the retina. So this is a kind of OCT, we are not sure what we are dealing with. So this is not a big deal as far as surgery is concerned. It's a normal VTL case, but what I'm saying is that at the end of this case, I just go ahead and put the MIOCT there to see if there's an underlying ERM or cystoid macular edema which needs, any kind of treatment. So a very handy tool, you can. So I'm just at the end of surgery, I'm just, seeing the fovea and seeing the macula if anything else needs to be done. So this is how the patient did post-operatively. So I think we might just be running short of time. So I think I will just close my presentation here with maybe this last video, which I'm not sure if you all caught in the 3D session, but this is 2D, and as I showed you that we can also use PFCL bubble when there's an old atrophic macular hole where you realize that the flaps are not plugging the hole nicely, and you can see that the flaps are all hanging outside the hole. I put a bubble of PFCL, and with the finesse I gently stroke the ILM into the hole and make sure that on MIOCT the hole is plugged. And this is how the patient is doing now. And maybe because there are anterior segment surgeons, we can use this for MIOCT. Of course, you can use it for cataract surgery, but this was something interesting. So these were silicon oil bubbles, not only in the AC behind the cornea, but also, it's a case of a coloboma iris and coloboma choroid. I'm removing these bubbles. I was not sure at what level these bubbles are stuck, but you can see these fascinating, images on MIOCT. With the soft tip cannula, removing these emulsified silicone oil bubbles, and then before closing the case, just taking it to the macula and making sure that things are okay at the back. Thank you.